a 71-year-old senator. He told his family he felt a little tired. Nothing else. A few hours later, the ambulance was in his driveway. Cardiac arrest. The preliminary autopsy, aortic dissection on a background of atherosclerotic cardiovascular disease. No warning, no crushing chest pain. He went from looking completely fine to gone in a matter of hours. That is the terror of aortic dissection. Today, I'm going to share with you 3 things directly. Number 1, why hardened arteries, the cause written on so many death certifications, actually misleads almost everyone. Second, why taking a statin to lower your cholesterol does almost nothing to prevent this tear. Number 3, the handful of things that genuinely lower your risk, and why nearly all of them are the most preventable, least drug-dependent things you can do. I'm Dr. Jing Duanyang. I've been practicing integrative medicine and psychiatry for over 30 years. Before we go deeper, just take 60 seconds, score 1 point for every line that is true for you. You have high blood pressure, especially if it is not well controlled. You're male over 60. You have a history of smoking now or in the past. A parent or siblings has had aortic aneurysm or aortic dissection, and you have been told you have a bicuspid aortic valve. You're tall and lean with long fingers and unusually flexible joints, or you have been flagged for muffin-related features. A scan once mentioned your aorta, your ascending aorta, was a little wide or mildly dilated. Here's how to read your score. If you hit 2 or more of the first 3, high blood pressure, male over 60, smoking, you're in the single most common high-risk profile there is. But if you checked any one of the last 4, family history, bicuspid valve, muffin features, or a dilated aorta, you do not wait for symptoms. You get imaging proactively. I will explain exactly why in a few minutes, so stay with me. How rare is this condition really? Aortic dissection hits roughly 3 to 6 people per 100,000 per year. Sounds really rare. But that number is a lie of omission, because a large share of these patients die before they ever reach a hospital. Some are only diagnosed on autopsy. So the real shape of this disease is low incidence, brutal lethality, and risk that clusters had in specific people. In the general population, it is rare enough that we don't screen everyone. But in the right person, it is not rare at all. Look at the data from IRAD, the International Registry of Acute Aortic Dissection, over 11,000 patients. High blood pressure is the most common driver, present in about 72 to 77% of patients. A history of atherosclerosis, about 27 to 31%. A non-aortic aneurysm, about 16%. 2/3 are men. Average age, about 62 to 63. Now go back to that senator. 71, male, atherosclerotic disease, family history of cardiac problems. That is not a freak event. That is almost a textbook portrait. Statistically rare, but not random. Here's what almost everyone believes. The artery hardens, it gets brittle, so it tears. That chain of logic is wrong, or at best, badly oversimplified. Let me show you what actually happens. Your aorta has 3 layers: inner, middle, outer. A dissection is a mechanical tear. High-pressure blood rips into the middle layer and split the wall into 2 channels, a true lumen and a fourth lumen. The blood carving a second path inside your artery wall. For that to happen, you need two things. One, the middle layer, the media, has to already be weakened and degenerated. Two, there has to be enough pressure, enough pulsatile force hammering that wall. Every risk factor you have ever heard of ultimately funnels into those two conditions. What does atherosclerosis actually do? Its rule is almost indirect. That is the part to really understand. First, the shared villain behind the curtain, high blood pressure. Atherosclerotic disease and dissection share the same number one cause, chronic high blood pressure. Sustained high pressure does two jobs at once. It accelerates atherosclerosis and it repeatedly shears the aortic wall, degrading that middle layer. The smooth muscle cells die off. Elastic fiber fracture. The matrix breaks down. So the reason these two diseases travel together is not that one causes the other. It is that they are both downstream of the same upstream driver. Second, atherosclerosis is a structural accomplice. Hardened arteries are stiff, less able to flex. A stiff aorta can't cushion each pulse of pressure, so wall tensions goes up, and yes, that can raise the tendency to tear. But here is the counterintuitive fact, the one break the myth wide open. In the classic proximal dissection, the type 1 tear, the tear often happens where there is not a dense plaque. Thick calcified plaques can even be locally protective. That's the paradox. Atherosclerosis is a marker of risk, not always the mechanism of the tear. Here's one sentence version. Atherosclerosis and aortic dissection are cousins, both raised by the same killer, high blood pressure plus aging. They travel together because they share a driver, not because they share a mechanism. That single fact explains the next one. Why statins can't save you from this. Let me be fair to statin first, because this matters. For lowering deaths from coronary artery disease, there is evidence for that, even though controversial. Statin stabilize plaque, cut heart attack risk, extend life. May be true, but statin target plaque disease in the coronary arteries. What tears your aorta is degeneration of the middle layer of the wall. Two different processes. This is to date no randomized trial evidence that statins reduce death from aortic dissection. Some observational data hints that statin users have lower long-term mortality, but that is heavily confounded by the healthy user effects and by compounding by indication. You cannot pull a cause and effects conclusion out of that. So, if you pin your hope of preventing aortic dissection on statin, you're aiming at the wrong target. The things that actually work and are more behavioral, more controllable, and far less dependent on a prescription pad. This is where my framework does the heavy lifting. 4 dimensions: anatomy, chemistry, energy, and soul. Let's start with anatomy. Monitoring and surgery, the only true life-saving measure. This is the one piece proven to lower mortality. Preventative elective surgery at a diameter threshold, generally around 5.5 centimeters for the ascending aorta. If you have muffin features, a bicuspid valve, or family history of dissection, that threshold drops lower, roughly 4.5 to 5 centimeters. The death rate for planned surgery is a tiny fraction of the death rate for an emergency dissection. And emergency surgery for acute type A dissection is the only thing that fights back against the mortality rate of 1 or 2% per hour. Untreated type A is almost always fatal. But hold on this finding. About 60% of dissection patients had a maximum aortic diameter under 5.5 centimeters at the time it happened. Diameter alone misses a huge number of people, which is why who gets screened matters even more than how big before we operate. Now come to the chemistry. There are a couple of drugs that slow the terrain, not reverse the structure. Beta blockers don't just lower blood pressure, they lower the rate of the pressure rise. It is the first drug in orphan or chronic dissection. ARBs, like losartan, target the pathway that drives wall degeneration. In Marfan patients, the randomized trial by Lacko and colleagues in the New England Journal in 2014 showed losartan and atenolol were equally effective at slowing aortic root dilation. Both worked. The COMPARE trial showed losartan beat placebo. Bottom line, in inherited aortic disease, ARBs are at least as good as beta blockers and often used together. One honest caveat: these drugs slow the rate of dilation. They're not proven on a hard mortality endpoint. The evidence is stronger for less dilation than for fewer deaths. Energetically, from the lens of Chinese medicine, aortic dissection is most extreme, structured expression of qi moving in rebelling, blood breaking its banks. Chronic liver yang rising qi and blood surging upward. Translated into modern physiology, that is the pulsatile shear force hammering the middle layer of the wall over and over. This isn't poetry. Centuries of attention, dizziness, head distension, a flushed face, a wiry hard pulse, that's a clinical description of a system with dysregulated pressure rhythm and excessive vascular tension. The treatment direction: calm the liver, anchor the yang, soften and nourish the blood, and settle the rebelling, points at exactly the same physiological target as our most important modern intervention. Control the pressure, lower the rate of pressure rise, quiet the sympathetic drive, make the force hitting that wall slower and softer. Food as medicine here favors gentle, palatable, everyday ingredients: gastrodea, crisp sesame, crisp seeds, mulberry, black sesame, nourishing rather than harsh. Here's the soul level: chronic stress, sympathetic overdrive, and the cost of always on. That senator was described and over as always working, always traveling, never stopping. That's not a footnote of admiration. That's a pathology clue. Chronic psychological stress through sustained sympathetic activation keeps the blood pressure up, heart rates up, and the load on the wall up. In the ACEs framework, imbalance at the soul layer transmits all the way down and lands finally on the aortic wall in the anatomic layer. Emotion, sleep, rest, rhythm, these are not soft wellness advice. They are physiological layers, acting directly on vascular tension. Here's the part you actually control. Let me rank the evidence clearly. Strongest first. Number 1, blood pressure control. The single strongest lever. High blood pressure is in over 70% of patients. It's the most preventable, most controllable factor there is. In non-aortic disease, the target is usually asystolic, on the 120 to 130. Number 2, beta blockers and losartan in inherited aortic disease to lower wall stress. Number 3, stop smoking. control blood sugar, reduce emotional and sympathetic load, all improve the terrain of the wall, and all sit entirely in your hands. One thing to avoid: flu-tolerant antibodies. Safety and observational data link them to high dissection and aneurysm risk. If you're high risk, avoid them when you can. Look at that list. Not one item on it is taking a statin. Everything at the top is behavioral, pressure, and rhythm. The most preventable, least prescription-dependent things you can do. Aortic dissection has almost no reliable early symptoms. The only thing that catches it in advance is imaging. CT angiograph or MRI angiograph directly measure aortic diameters and wall disease. Echocardium assess the aortic root. Who should be screened? People with high blood pressure, atherosclerosis, a smoking history, and most critically, the first-degree relatives of anyone who has had aneurysm or dissection, plus bicuspid valve and inherited aorta parents. Genetic evaluation, Marfan or Loeys-Dietz vascular disease, familial TAAD, tell us who needs earlier, more frequent imaging and a lower surgical threshold. Here's the clinical trap: a clean heart workup that only looked at your coronary arteries and never imaged your aorta. Let this deadly pattern stay completely invisible. If you have high blood pressure or vascular risk, a baseline aortic image belongs on the list. This is an emergency. If any of this happens, do not wait. Call for ambulance immediately. Sudden, severe, tearing chest or back pain, often described as ripping radiating to the back between the shoulder blades, pain that is maximum internally instantly rather than building gradually. Pain with fainting, altered consciousness, one-side weakness, or a lost pulse. In a high-risk person, any chest or back pain, unlike anything you have felt before. Time is life. A type A dissection kills at 1 or 2% per hour. If you or someone you love fits today's high-risk profile, go to accesswell.com. Inside the member area, you will find the Aortic Health Self-Assessment Protocol, a downloadable PDF to map your personal risk. The Calm the Liver Anchored Young Food Therapy Plan, exact ingredients, dosing, and a 4 weeks rhythm, and the which scans to ask for doctor conversation checklist, so you walk in prepared and stop waiting on symptoms. Individual diagnosis and prescriptions live inside Young Institute clinical practice. This public content gives you the framework and the tools. It doesn't create a doctor-patient relationship. If this reframed how you think about your heart, share it with one person in your life who checks those risk boxes. It is a 5 minutes forward that could be reason they get a scan. I will see you in the next one.